Good afternoon all. I am Dr. Aparna Krishnan. As we all know, abnormal action potentials can lead to the development of amblyopia, and patching is the most widely advised and most followed treatment for amblyopia, even though it shows only 70 to 75% improvement. So there is a need for other modalities to develop to treat amblyopia. So how orthoptic magnocellular is different? It causes repeated foveal fixation by targeted movement, repeated visual cortex stimulation, and it uses saccadic movement and attention mechanism. Saccades, as we all know, are short, fast eye movements lasting for 50 to 80 milliseconds, and it causes posterior parietal and lateral visual cortex stimulation. We use two mechanisms of attention: overt attention, where the eye moves to the peripheral stimulus to ensure foveal fixation, and covert attention, where the patient fixes on the central light and can still see the peripheral lights. These two mechanisms stimulate the occipital, parietal, and the frontal cortex. So whenever there is a sudden appearance of light, there is stimulation of the magnocellular pathway, which leads to the generation of a saccadic movement. So it will lead to the stimulation of saccadic movement and attention mechanism, which is associated with stimulation of the fovea and the visual cortex. When this occurs repeatedly, there is repeated stimulation of fovea and the visual cortex. So we decided to study the effect of orthoptic on our population, and we conducted a prospective study on a time period between March 2022 to March 2023. And we included all types of amblyopia patients with an age group of more than 5 years of age and with the visual acuity in the worst eye more than or equal to 6/60, and intermittent exotropia patients with a Newman-Castle score between 3 to 4. So how to do this procedure? So it consists of 2 sessions. For each session, the good eye is patched for 20 minutes, followed by amblyopic eye for 5 minutes, and then with both eyes open for 5 minutes. So the first session, as we are seeing in the picture, the child is placed in front of the screen. The screen consists of a red light in the central, which is surrounded by white LED lights. So first, the patient is asked to point to the light on the screen with a pointer, which stimulates the overt activation. And the second session, that the patient will focus on the red light and count the peripheral lights that switch on continuously. And this stimulates the covert attention. So these 2 sessions are repeated after 1 hour, then daily for 10 days or twice a day for 5 days. After 10 sessions are completed, we analyze the visual acuity, PBCT, stereopsis, and BSV. And if there is improvement, the patient will be going to the tapering dose. And if no improvement, we will be stopping the treatment. So we did study in 110 patients, 90 patients of various types of amblyopia, and 10 patients of intermittent exotropia. And the mean age was 10.87, ranging from 5 to 25 years, and 52% of females and 48% males. As from the chart, we can see that majority, the anisometropic, strabismic, and ametropic amblyopia patient showed an improvement more than 73%, and we could see that there was an 80%, more than 80% improvement in anisometropic and strabismic amblyopia patients. And all of the patients who showed the improvement showed the improvement in at least two-line improvement in the logMAR chart, with a maximum of 15 letters in anisometropic and ametropic and 13 letters in strabismic amblyopia patients. In the intermittent exotropia patient, we noticed that the NCS score of 3 to 4 improved to NCS score of less than 2 after the treatment, and 6 patients showed improvement in stereopsis. So we all know that these are the main methodologies which we follow for amblyopia therapy, but Motor study has found that average concordance with patching was 48%, and more than 80% of the improvement during occlusion occurred in 6 weeks. That is where OMS is different, because patching has very side effects such as poor compliance, strained parent-child relation, longer time for improvement, difficulty with day-to-day activities, and it is time-consuming for parents. So OMS use both monocular and binocular during the treatment, faster improvement in 10 days, happy parents, and therefore better compliance. So we are comparing our study to a study published in IJO by Sandan Gopal et al., where he studied 35 patients and we have compared 110 patients. Anisometropic and strabismic amblyopia were studied in his study, and we included all types of amblyopia and IXT patient, and we got comparable improvement in anisometropic and strabismic amblyopia of 80%, similar to his study, and in both studies, no regression was noticed in the follow-up. So possible causes of failure could be dense amblyopia, long-standing amblyopia, older the age group, and discontinuity in treatment. So our study, it is the largest study population where all types of amblyopia were studied and studied the utility in IXT and more promising results in anisometropic and strabismic amblyopia. So to conclude, OMS is excellent results in shorter period of time, and it gives excellent result in anisometropic and strabismic amblyopia, and we can obviate the need for an immediate surgical intervention in IXT. Thank you.
Thank you so much. So you had better outcomes in children up to 11 years of age then, in that case?
Majority up to 11 years of age, madam. As age was more, we had 25 years of age patient also,
yes,
but they didn't show much improvement.
Right.
We noticed up to 11 years we had more improvement.
Okay, and what about the level of amblyopia for dense versus mild, moderate?
Actually, 2 to 3 patients had a dense amblyopia. We didn't get much improvement with dense amblyopia patients. The dense and longer duration, we didn't get much improvement.
Sure. Even if they were younger, much younger, less than 4 or
no,
less than 3?
No.
Okay, thank you.
Anything, just
neural plasticity. Now you are claiming 11 years, 30 and some more times. What about the old neural plasticity theory? Have you heard of neural plasticity
yes,
theory? What is that?
Up to now they are claiming even up to 20 years of age, the plasticity connections can develop. We can try amblyopia therapy even after 12 years of age.
Oh, that's why I'm saying, no, that was the 100 months. So what is now status? Have you gone through any literature of this? Or how can you say this is only on the brain level? Or is it on the corneal level? Okay, fine.
No, till now we haven't noticed any regression. 45 patients had 1 year follow-up. Mean follow-up is 6 months, madam. We didn't notice any recurrence.
Answer sheet.
Thank you, well done. So, can we have the next speaker? Can I proceed? Our next speaker, Dr. Shruti Nishant.
Good morning, everyone. So today I'm going to be presenting my report on the effectiveness of the defocus incorporated multiple segments lenses in myopia in Indian children. I have no financial disclosures. So the DIMS lenses are actually lenses that have a central 9 mm clear zone followed by a periphery of around 400 multiple defocus segments which are plus 3.5 diopters in refractive error and refractive power, and they actually create a myopic defocus on the retina, correcting or preserving the myopic progression. So how they work is the myopic eye is found to be more steep in the posterior pole as compared to the periphery. Thereby, a single vision lens may only correct the posterior pole, whereas create a hyperopic defocus in the mid-periphery. By creating a myopic defocus, these lenses actually correct the image onto the retina, thereby providing a clear image. And that's how they work. Now, the pros of these lenses are they are non-invasive, they are comfortable, they have good compliance because the child is anyway wearing the glasses, and they can be used for pre-myopes as well. Now, the purpose of our study was to have the clinical short-term effectiveness based on the cycloplegic refraction and the axial length. We included children who were 7 to 17 years with progressive myopia. Children's refraction ranged between 0.5 diopter to 9 diopters with astigmatism less than 1.5 diopters, and children who did not have any previous experience of myopia strategies. We excluded children who had strabismus and binocular vision abnormalities or any other ocular abnormalities. So the children, this was an 18-month study. We included 50 children with 100 eyes with an informed consent from the parents. The children were monitored over 4 visits. The first was the baseline visit, second was V1, V2 and V3. Baseline visit, all the children were given single vision glasses and followed up for a period of 6 months. At 6 months, that was the V1 visit, they were divided into 2 groups, the control group who continued to wear the single vision glasses and the study group who were then shifted to the DIMS lenses. The second, these 2 groups were then followed up for 6 months and then 1 year. At every visit, the axial length and the cycloplegic refraction was measured. These were the results. Between the controls and the DIMS, we can see the mean age was 10.5 and 10.8. The mean refractive error was minus 2.9 in the controls and minus 4.2 in the DIMS. The mean axial length was 24.2 and 24.9 in the 2 groups respectively. So when we come to the comparison of the refractive error, we can see that from baseline to V1, in both the controls as well as the subjects, study subjects, the mean progression was 0.76 diopters, and in the study subjects was minus 0.8 diopters, so pretty much similar. This was statistically insignificant. When they were followed up for a period of 6 months, the study subjects showed a mean progression of minus 0.16 diopters, plus or minus 0.2 diopters, and over a period of 1 year, it was minus 0.24 diopters, plus or minus 0.2 diopters. As compared to the control subjects, at the end of 1 year, they had a progression of minus 0.7 diopters. Now, the difference between these 2 groups at the end of 1 year was minus 0.46 diopters, and the refractive error control was 65.7%. So this is the axial length. Sorry. Yeah, with regards to the axial length, 0.29 and 0.33 at the V1 visit, and at the end of 1 year, 0.3 and 0.13 was the thing. The difference between the 2 groups was 0.17 mm, which was statistically significant. The control in the axial length was 56.7%. The change in the absolute change in the refractive error over 1 year, this is the blue is the control group, the orange is the DIMS group. We can see that this is the number of subjects and this is the absolute change. We can see that 16 subjects had 0 diopters of change as compared to 4 in the control group, and 0.25, 19 subjects versus 10, 0.5 diopters, 12 versus 8, and we can see that none of the patients had more than 0.75 diopters in the study group. Overall, we found that 94% of the children with DIMS had progression of less or more equal to 0.5 diopters at the end of 1 year. These were the changes. We did find that 3 children did not have any effect on progression, that was 12%. So the discussion, refractive error was slowed by 0.46 diopters in 1 year, axial length by 0.17. The effect of DIMS was more robust in the first 6 months. 32% had no progression in the DIMS group and 50% had 0.25 or less. We also found 28% of controls did not progress, which gives us reason to believe that we should wait for 6 months before starting myopia control strategy. When we looked at the other studies, the Lam et al. Study was done for 2 years, which was the initial study, and we could find that it was comparable to the Lam study. The strengths of our study was that we had a control group, we also had a self-control group, and we started them only on children who were on progressive myopia. The limitation was the sample size, the short follow-up, and we did not measure relative peripheral refraction, and we did not also see the rebound phenomenon. So this is my conclusion slide. We can see the statistically significant control of 0.46 in 1 year and 0.017 millimeter in 1 year. Thank you. Yes, ma'am. So we did not.
DIMS without doing peripheral refraction.
Yes, ma'am. So for both controls and DIMS, this was done, I think we started at 18 months, so this was almost 2 years back.
Sure.
So at that time, we started them without checking the peripheral hyperopic refraction.
Okay. So by checking the peripheral refraction, how would you have differed in your...
What we did, ma'am, 3 children did not respond.
Yes.
So though I cannot comment on the others because we have not followed all of them yet,
Yes.
the 3 children who did not respond, we did check their refraction. They had peripheral myopic defocus.
Okay.
So that was done as an afterthought because they did
Yes,
not respond to
yes.
the, did not completely respond to the
Yes.
the spectacle at all. So,
Sure.
So that was one of the
That would be
limitations.
a
of it.
limitation,
Yes,
isn't
ma'am.
it? So
That
you
is
should have mentioned that.
I did mention that, ma'am. It was there.
One thing more. Now, initially we go by that definition, then there should not be any anatomical or physiological something like error. So did you check corneas?
Yes, sir. So
Wow.
the initial inclusion, we excluded all children who had any other ocular or systemic
No,
abnormalities.
these also higher order aberrations, or for that did you check that?
Sir, all children underwent topography. That's part of the myopia workup. So if there was
Have-
anything...
Have you analyzed that data?
So we excluded the children who did not... We did not do an aberrometry, sir. We did a topography.
Suppose cornea is clear, but
Yes, sir.
on the surface there is something. Why I am asking again and again?
Yes, sir.
After the refractive surgery, we are seeing then patient who are having, even of 40 age, who are having the laser for the higher order. Their initial vision is 6 to 18 or 20, and they are improving to 6.9.
Yes.
Or sometimes there is one surgeon who claim that after putting cataract surgery, patient again come to the 6/6. So my point is that looking for the cornea and other things. So the retina, or initially we used to thought or teach that at that time only retina is responsible. From this decade only corneal research has come, and now we have so many parameters.
Yes, sir. I agree, sir. Sorry, we did not see the aberration, but for these profiles for these patients.
यार कोई किसी को भी कहीं बिठा दिया है.
Thank you so much.
Thank you.
Well done. Very good. So we'll have the next. Can we call the next? Vaishali, Dr. Vaishali.
Can I have my presentation? Oh, sorry. A very good afternoon to the august panelists and everybody sitting here. Today I will be talking about 7-year post-operative outcomes following IOL implantation in the bag with anterior vitrectomy or posterior optic capture without vitrectomy in children below the age of 4 years as a randomized clinical trial, and we have no financial interest. We started this study several years back to compare long-term outcomes, mainly visual axis obscuration and other serious post-operative complications following cataract surgery and in the bag IOL implantation with anterior vitrectomy, which is a standard surgery protocol for all children below 4 years for most of us pediatric cataract surgeons, versus posterior optic capture. That means IOL placed in the bag and the optic captured through the PCCC, and no vitrectomy being performed in these eyes even if the child was below 4 years. This was a prospective randomized controlled clinical trial, and 61 eyes of 61 children were enrolled initially. No other ocular comorbidities or surgeries was an inclusion criterion, and of course consent was obtained. The same intraocular lens, a 3-piece hydrophobic acrylic IOL, was used in both groups. In group 1, we performed limbal anterior vitrectomy, manual anterior and posterior capsulorhexis, and in the bag IOL. Whereas in group 2, we performed same manual anterior posterior capsulorhexis, same 3-piece lens, but after placing the IOL in the bag, the optic was slid behind the posterior rhexis margin to attain an optic capture. Again, the most important difference, no anterior vitrectomy was performed in these eyes. And like I said, standardized protocols and parameters were used. For this report, we are reporting up to 84 months follow-up, and we performed an examination under anesthesia for any child whenever we felt that we could not capture whatever outcomes measures we needed, which included VAO, significant VAO, that means coming into the central visual axis, and that required an intervention during any time of this 7 years follow-up was documented. Glaucoma obviously was looked at, and inflammation in the terms of cell deposits or posterior synechiae, or the need for an anterior membranectomy. Now group 1 and 2 each had 30 and 31 eyes enrolled. The mean age in both groups was about 18 and 15 months of age. And in both groups, about 45% children were below the age of 1 year. So this is the most crucial time for VAO and other complications. So half of our patients almost were in that age group. Our mean follow-up for this report was 95 months. In group 1, it was 97 months. And in group 2, it was about 100 months. And it's a very important data that only about 75% children in both groups completed the follow-up, and this was after free follow-ups. These were all without any charge, and where we had to call the patient and keep scheduling follow-ups. Still 25% in both did not finish more than 5 years of follow-up. At final follow-up, mean visual acuity in both groups was quite good, 0.6 logmar, comparable, no statistical difference. 3 eyes in group 1, that means where vitrectomy was performed, and only 2 in group 2 where capture without a vitrectomy was done, needed any secondary procedure for a significant VAO. And where these were performed, most of these, if you note, were performed within the first 2 to 2.5 years after surgery in both groups. But in the optic capture group, both eyes were a little later, 21 and 30 months after surgery. So yeah, the point is that with newer techniques, lesser children are now needing VAO surgeries, but whatever happens is mostly in the first 2 to 3 years after surgery. Same thing in a tabulated form here. If you can see here, in both groups, the number of VAOs were comparable, no statistical difference. And if we look at children below the age of 1 year and above the age of 1 year, when we looked at the incidence of glaucoma, 2 eyes in the bag and vitrectomy group developed glaucoma versus 1 eye in the optic capture group had, but this eye was above the age of 1 year. So yeah, glaucoma incidence, no statistical difference, but there was no additional glaucoma by performing an optic capture. In fact, if at all, maybe less. We do realize that this is a skill-dependent procedure and you need a perfectly sized and centered PCCC. So this is something particularly in children below 6 months, it may be a limitation to perform, but above that, we find that it is very useful and the complications and visual acuity seem comparable. Why do we want to do this? Because if we can eliminate an anterior vitrectomy, which is an additional procedure in an unknown, non-visualized area, you may be helping the child in terms of glaucoma or other long-term complications. So I think this is the longest reported follow-up in a randomized manner of this technique. Thank you.
Thank you, Vaishali. So, do you want to start? You want me to start? Okay. So based on your study, you're trying to say that VAO was less significant in children?
No, it was comparable with both techniques.
It was comparable.
Yeah.
And glaucoma between 2 and 1. So
that's also comparable.
Yeah. So how can you conclude that not doing an anterior vitrectomy may be a better?
What we are saying that is a good option and it is equally safe and effective. Right. As compared to the standard protocol, where you could avoid one additional step and still have equal. We are not saying one is superior, but they are both comparable.
Yes. So you're talking about comparison between visual axis opacification and glaucoma. What about other parameters? Lens position, whether lens was tilted or not in this particular follow-up period. Or let me finish, post-operative inflammation. There are so many parameters we look at post-operatively in a child, which is responsible for not only their vision, but also their inflammation and all other things, their refractive status. So have you looked at all those?
Yes, ma'am.
It's only these two parameters?
No, we have looked at the primary outcome measures were vision, glaucoma and visual axis obscuration, but inflammation was evaluated in the form of cell deposits and synechia, and there was a comparable incidence in both. And we are looking at UBM studies in these, like you said, because these are below 4 years. It's very difficult to evaluate clinically, but our UBM studies are ongoing in terms of position. And we do see anterior capsule phimosis in the capture group. But fortunately, none of these eyes have been severe enough where they have come into the pupillary area and necessitated an membranectomy or enlargement. So yeah, that's a very valid
refractive status, astigmatism?
Astigmatism is comparable. Yes.
So I have a question. What are the surgical complications you encountered? Capture sometimes doing it in a 1 year versus a 4-year-old, the posterior capsule would be different. So saying that it's a reasonable alternative, what about the surgical issues which you probably must have had and you would like to know?
True, Dr. Sukhija. That's I think the most important part, that like I mentioned also, it's very difficult to perform in children below the age of 6 months. And we had 3 eyes out of the 31 that were recruited, originally scheduled for capture, where we ended up having a vitreous phase disturbance. And therefore, we had to perform an anterior vitrectomy. So in all these protocols, obviously, you stain the vitreous, and if there is anything, we had to do a vitrectomy. And in 1 eye, we could not perform an optic capture. But other than that, again, this is with experience we could do in younger children, but I do acknowledge that below 6 months particularly, this is a very difficult technique. Thank you.
We'll move on.
Yes. So that's again a thing, that single piece hydrophobic, but when you capture, because of that thick optic-haptic junction. No, that also has a 3-piece. Correct. Yes. Yes, that would be a more real-world comparison, but when we look at scientific data, we were being questioned that why would you compare apple and orange? So to keep everything uniform, we have made a standard methodology.
Thank you so much. Let's move on in interest of time. Dr. Ankita Aishwarya for the next talk.
Meanwhile, just we were utilizing the time. So how many cases were the bilateral and unilateral? Talk on later on. Okay, fine.
A very good afternoon, everyone. So I'll be presenting our work on sirolimus, a ray of hope for complex orbital venolymphatic malformation in pediatric patients. We have no financial disclosure. Well, venolymphatic malformation are benign hematomas, which typically present in the first decade of life, constituting around 1 to 4% of all the orbital lesions. There are various ways to classify them. Based on depth, it can be classified. There are various ways to classify them. Based on the depth, it can be classified as complex if it involves brain, head, or neck infiltration. And if there is no response to the previous treatment, then it also called as a complex orbital venolymphatic malformation. There are various management options. First, surgical debulking. However, higher recurrence rate, worsening of the cranial nerve deficits, and loss of vision has been documented. The second option is sclerotherapy. It's more effective for macrocystic variant rather than microcystic. However, still there is a higher risk of infection, compartment syndrome, and permanent vision loss. The third is the medical therapy. In medical therapy, well, sildenafil is more effective in macrocystic cases. Systemic steroids are generally not effective, and sirolimus is effective in both radiologic and functional improvement. However, till now, there are no guidelines for managing complicated orbital venolymphatic malformations. A word on sirolimus, it's a macrolide antibiotic which inhibits mTOR pathways. It reduces the cell growth, lymphangiogenesis. However, we have limited data on its role in orbital venolymphatic malformation, possibly due to the rarity of this condition. So based on this background, the purpose of our study is to evaluate the safety and efficacy of oral sirolimus in these cases. Our primary and secondary outcome measures are the following. We did a prospective cohort study, a detailed ophthalmological examination, radiological examination, pediatrician clearance, and baseline evaluation. The inclusion-exclusion criteria are the following. Our patients received sirolimus orally at the rate of 0.05 milligram per kg body weight twice daily. Our target serum sirolimus level was 5 to 15 nanogram, which was monitored at first month and then 3 monthly throughout the treatment period. All patients have received sulfamethoxazole and trimethoprim as a prophylactic measure for pneumocystis pneumonia. The response was divided into complete response, partial response, and absence of response. Coming to the results, out of 21 patients, boys dominated the study with a mean age of 12.7 years, and all cases were unilateral. All of our patients have received previous treatment elsewhere, either in the form of sclerotherapy or surgical debulking. The main presentation was proptosis followed by redness. The duration of symptoms ranged from 15 days to one year. The area of involvement in our cases was isolated orbit in 6 patients, orbit and PNS in 5 cases, orbit and scalp in 5 cases, orbit, PNS, and oral cavity in 3 cases, and orbit and brain in 2 cases. Results, well, the mean duration of treatment was 6.5 months, and at the end of the treatment period, our mean sirolimus concentration was 8, which was within the therapeutic range. Our mean follow-up was 15.2 months. Coming to the outcome parameters, the first, resolution of the lesion. Well, complete response was seen in 62% of the cases. Partial was seen in 33% of the cases. And one patient has recurrence and no response because of loss to follow-up. The second parameter, visual acuity improvement, it was clinically significant. The third parameter, reduction in proptosis. Well, the mean improvement was 2.5 millimeter in our case series, and it was clinically significant. The fourth parameter, safety. Well, our patients have had a mild reversible adverse effects, and one case had recurrence because loss of follow-up. Let's have a look on few examples. So this was a 10-year-old girl who had received sclerotherapy and presented to us with chemosis, diplopia, and proptosis and decrease in the vision. With 4 months treatment of sirolimus and 13 months of follow-up, her vision has improved and the proptosis has decreased. This was a second case of 8-year-old boy who had received sclerotherapy and the vision was 8 hand movement. The lip and the palate was also involved. At 12 months of follow-up with sirolimus and 14 months of follow-up, the vision has improved. There is no proptosis, but there is a mild inferior dystopia was present. Resolution of the palatal lesion was there. However, the lip residual hypertrophy was still present. And even on MRI, you can see that there was residual superior orbital lesion was still there. The third case, so she was a 16-year-old girl who had underwent debulking surgery and sclerotherapy elsewhere. You can see the scar mark here. She has undergone 9 months of treatment with sirolimus, and with 18 months of follow-up, her vision has improved and proptosis has decreased. If we compare the various modalities of treatment for orbital venolymphatic malformation, our sirolimus is having a comparable response and the recurrence rate is lower. If we compare to different studies where sirolimus has been used for complex orbital venolymphatic malformation, so with a larger sample size, lesser duration of treatment, the response is better and minimal side effects. These are our limitations. So to conclude, sirolimus is a promising and safe therapeutic option in complex venolymphatic malformation cases, especially where the conventional treatment has proven ineffective. It provides a ray of hope for patients facing challenging malformation. However, a larger clinical trial are needed to clarify the optimal length of treatment use as well as monotherapy. Thank you so much.
Any side effect did you find in these cases?
Yes, ma'am. So there were mostly systemic side effects were there, which were mild and reversible. Like there was mild leukopenia was there, gastric disturbance was there. Some patients also have mild neutropenia, but those all were reversible.
And what was the time period of the study?
So we have done 15.2 months follow-up, ranging from
15 months. So
yes, sir.
Your hospital is tertiary hospital?
Yes, sir. Tertiary care center, SGPJ Lucknow.
Okay, fine. Thank you. That's why you are getting so many patients in
Yes.
50. It's good, very good.
Thank you, sir.
Next presenter is Dr. Riya. And I'll request the next speaker, Dr. Rolika, to be ready.
Good afternoon, everyone. I'll be presenting my study on the comparison of predictive accuracy of partial coherence interferometry and swept source OCT-based biometers for IOL power calculation in a pediatric population. Optical biometry is now the gold standard not only for adult but also for pediatric populations. Among the two biometers we have studied, IOL Master is the more commonly used one based on partial coherence interferometry. It uses a light source which has a 780 nanometers wavelength, and the axial length measurement uses a single refractive index for all tissues. Argos is a newer SSOCT-based biometer using a light source of about 1000 nanometers. It uses refractive indices which correspond to each tissue, which gives an improved tissue penetration, better image quality, and improved signal-to-noise ratio theoretically. Recently, there have been studies comparing both these barometers in adults undergoing cataract surgery. However, there is a lack of literature comparing the predictive accuracy of these biometers in a pediatric population. Therefore, the purpose of this study was to compare the predictive accuracy of IOL power calculation made with these two biometers based on different principles in children aged 5 to 15 years. This was a pilot study in which we included 5 to 15-year-old children diagnosed with developmental cataract. We did preoperative IOL power calculations using both IOL Master and Argos biometers. The axial length, keratometry, anterior chamber depth readings were obtained. IOL power was calculated using the SRK-T formula. All patients underwent lens aspiration, primary posterior capsular excess, and anterior vitrectomy, and the IOL placed in the bag for all patients. Refractive outcomes were measured at 4 weeks post-op by manual refraction. The prediction error was calculated at the post-operative spherical equivalent minus the predicted spherical equivalent. And we measured the absolute prediction error and the mean value of absolute prediction error. These statistics were performed using the SPSS software. Mean K, axial length, anterior chamber depth, prediction error, and absolute prediction values were compared using the Wilcoxon sign rank tests. Pearson correlation coefficient was calculated for each parameter, and statistical significance was p-value of less than 0.05. So in our study, we had a range of 8 plus minus 3 years. The predictive mean prediction error was comparable in both the biometers, and the mean value was 0.59 in the PCI-based biometer and 0.46 in the SSOCT-based biometer. There was a strong positive correlation between the biometers for axial length, keratometry, and anterior chamber depth readings, and the difference in the mean absolute prediction error was not statistically significant. These are the histograms showing the mean absolute prediction error values for Argos and IOL biometers. In the discussion, there have been studies which give varying results. There are studies done in adults in which both these biometers based on SSOCT and PCI base have shown good correlation between the values. However, some studies do report that in medium long eyes, the SSOCT based biometer gives better results. The limitation of our studies was that we included children in whom biometry was successfully performed between both biometers. Therefore, success rate of acquiring the measurements was not examined. Also, we only took children above 5 years of age, which excluded children younger who have more chances of prediction error in calculations. In conclusion, pediatric, the predictive accuracies of PCI-based biometer, IOL master, and SSOCT-based biometer, ARGOS, were comparable. We found a strong positive correlation between the two biometers for axial length, keratometry, and anterior chamber depth values. Therefore, an SSOCT-based biometer could be a useful tool in preoperative IOL power calculation in children. However, we do recommend that future research with a larger pediatric study population with varying axial lengths is warranted. Thank you.
No, because your mean age was 8 something.
Yes, sir.
So by that time, the development of eye is already completed. So what is the real aim of your study?
We do, because there is a availability of newer biometers, we do want to compare between whether the commonly used biometers like IOL master.
No, my point is simple.
Yes, sir.
Because how these kids are different than adult, because all the development has already taken place. My point is this. So what is applicable for the adult, this will be applicable for 8 year plus old child. My point is that. So how it is going to different for that? Because we need, we are facing difficulty between 0 to 2 and 2 to 6 most of time. So that is the dilemma for most of the pediatric ophthalmologists. After 8, things are very much clear like that. Even so, that's why I'm asking what was the aim for your study?
If we do the study, then it is
you
better
want to
clearer.
contribute for the literature?
Yes.
Okay, fine.
Thank you.
And you are the main investigator or somebody else has?
I am the main investigator, sir, under the guidance of my chief author.
Okay. Who is your chief author?
Dr. Sumita Agarkar, ma'am.
No, that's okay. Means like, is he your consultant,
Consultant,
or
yes.
your teacher?
My teacher, yes.
Okay, fine.
Dr.
Yes.
So power of the study is very low. 69.
That's why I'm saying.
The study is very low. They'll have to do hundreds of patients to get accuracy.
Because he is very young, so we want to just give some insight to do better studies and all that. That is the idea only.
Yes.
Thank you.
Thank you.
Dr. Rolika, next. And the next presenter, Dr. Ruhi, be ready on the other side.
Okay, may I begin? Okay. A very good afternoon to all of you. And today I will be talking about rekindling the flame of hope and for children with ocular cancers. So when it comes to ocular cancers, we can say easily that it hits differently when it hits children. And early in life, a battle with ocular cancers can have a deep psychological impact on children and their families with loss of hope, often leading to radical measures like enucleation and life-threatening complications. And let's see how plaque brachytherapy has revolutionized the world of pediatric oncology. We have no financial disclosures, and I will be discussing ruthenium-106 plaque brachytherapy in pediatric ocular tumors. Let me give you a brief description. Out of all the radioisotopes available, ruthenium, which is a beta emitter, that is what we utilize, and it is electroplated on a silver coil, and the silver coil is sandwiched between a silver plating backing that makes the plaque. And that's exactly what we place over the tumor, causing tumor regression. And the purpose of the study, let's not forget that ocular tumors, they leave a psychological impact. It leaves a long-lasting psychological impact on children and their families, and it affects the children during the most important phase of their life, that is the growth phase of life. So our purpose was to assess the outcomes of the spectrum of pediatric ocular tumors treated with ruthenium-106 plaque brachytherapy. So we conducted a retrospective interventional consecutive case series with 94 eyes over 10 years, and we assessed vision, eye, and life salvage. All pediatric cancers were included except for the ones with baseline metastasis or loss to follow-up. The tumors constituted to be 20% of all the plaque brachytherapy tumors that were ever treated at the center, and let me tell you, that's not a small number. And the age ranged from mere 1.5 months to 16 years. The spectrum that we saw, majority of the cases were of course retinoblastoma, 68%. We also saw choroidal hemangioma, retinal hemangioma, ocular surface squamous neoplasia, ciliary body medulloepithelioma, choroidal melanoma, conjunctival melanoma, and myofibroblastic tumors. And this is not a very small spectrum. And we treated the tumors ranging from 30 gray to 100 gray. It depends on the etiology. That's how we choose the dosage. And the complications were radiation retinopathy in 10%, cataract formation, corneal opacity, which were taken care of. And we achieved a vision salvage of 55%, eye salvage of 90%, and life salvage of 100%. And that's a revolution per se. Over the past decades, when we do the review of literature, retinoblastoma has been treated with plaque brachytherapy, and it's 1993 when it was stated that it can be used as primary or secondary tumor with good tumor control and patient survival. And the same study group has also analyzed them in long term, and they've stated good control at 1 and 5 years also, with complications similar to ours. When we do a complete analysis over here, this is the study for retinoblastoma evaluation of plaque brachytherapy, we see that over the years, multiple radioisotopes were used. In our study is the first study which utilizes only ruthenium with a apex dose of 45 gray at a 7.8 years follow-up. And a vision salvage, eye salvage, and life salvage have only increased over the years. And so we can say that plaque brachytherapy is universally acceptable treatment modality for retinoblastoma. Excellent outcomes have also been reported in diffuse choroidal hemangioma. These implications have been successfully extended as novel treatment modality for several ocular tumors. And this reduces psychological impact by increasing eye and life salvage. So to conclude, advent of plaque brachytherapy in pediatric tumors has revolutionized the outcomes in several etiologies. The dose that we use is 30 gray to 100 gray, depending on the etiology. Complications are associated with minimal functional impairment, excellent vision, life, and eye salvage, and this reduces psychological impact in their lives. And we must remember that sometimes real superheroes live in the hearts of small children fighting very big battles. And I thank the entire ocular oncology team for their efforts in keeping the flame of hope alive.
Thank you. Good presentation. So I just wanted to ask you, in your really last series, all these were primarily and only treated with plaque brachytherapy, I guess, or there was no additional adjunctive therapy or treatment or chemo that was given to any of these?
Yes, there is. So in cases with retinoblastoma, it's always adjunctive treatment. Most over the plaque brachytherapy was utilized as primary treatment earlier days in 1993 or so. But henceforth, like in the current days, we use plaque brachytherapy only in the recurrent cases.
But your study period is these 10 years, correct?
Correct. In the 10 years, it has been used only for the recurrent cases. For the retinoblastoma, it's only the recurrent cases.
And this is the only therapy that was used in your series? There was no additional adjunctive therapy?
When plaque brachytherapy is being given, nothing.
And
that
before
time,
or after, there may be...
Correct. Before it must have been done, like
No,
chemotherapy.
I mean, when you talk of outcome of plaque brachytherapy as such a revolutionized, you also have to put that caveat that this is not the only... So the message should not go that this is not the only therapy. This is one of the adjunctive, but now currently used in selected few as the primary, correct?
That is true. So like in the earlier times, they had started using plaque brachytherapy as primary treatment also, but it was taken away because the chemotherapy is primary importance. So plaque brachytherapy is currently, in the past 10 years or so, only used for the recurrent cases. And that is when everything has failed and then plaque brachytherapy becomes...
This is the last line treatment?
Yes, mostly.
Okay.
Just one question. Are you the dose is given here in your site, or the radiotherapy person, they are also involved in the process?
Yes, the team of radiology, that is like there's a
they are the radiotherapy.
Right. So the radiation oncology team is also involved. They're the ones who calculate the dose, but per se the radiation is done by us. The calculation is done on the basis of a simulator. There's a proper calculator which decides as per the apex dose how much should be the surface on the side. There should be no complications, and they give us the dose.
Okay, thank you.
One thing more. The hemangioma also, that is like not malignant for that.
Yes.
Did you use the plaque?
Yes, and it gives very good.
How long? How much time? This is 10-year-old study. So when did you just enter in this study? So how long were your associate, personal associate?
My association has been for past 4 years now. More than 4, I guess. Yeah. Right.
Logistic problems in children when you're doing this?
Logistic issues are always there, sir, like in terms of, say, when we have complications like cataract surgery, so that's like another surgery going through, but that was in very few cases. The logistic issues are also that when the plaque is placed, the children are very, not that comfortable, but that's only for those few hours or few days that the child remains like in discomfort.
Sedate these children when
Yes, yes, the procedure is done under sedation.
A very good afternoon to one and all present here. Today I'd like to present my topic on unraveling the genetic puzzle, genotype-phenotype association in aniridia. Aniridia is a congenital partial or complete absence of the iris. It is a rare panocular disorder affecting cornea, anterior chamber, iris, lens, retina, macula, and optic nerve. The prevalence is up to 1:1 lakh in the population. It is resulting due to an insult during the 12th to 14th week of intrauterine life. Mutation in the PAX gene, short arm of chromosome 11, is noted. The aim of the study was to check if there was any phenotypic association of aniridia. Methodology, ethics committee approval with detailed consent was obtained. Prospective study, all subjects with aniridia and family members with the similar phenotype were tested. Detailed history, examination, intraocular pressure evaluation was done. Genetic analysis was done. First and foremost, of course, a written informed consent, which was detailed in nature. Exome study was done, wherein a single gene mutation was identified. The mutation was confirmed by single genome study in affected family. The whole genome sequencing was done. Novel PAX6 gene mutations in all the 11 patients, autosomal dominant inheritance. Autosomal dominant inheritance, we should note, does not have any systemic associations. It is the most common presentation. About up to 85% of patients found to have aniridia have autosomal dominant inheritance. Out of the 11 patients, 6 were females and 5 were males. Likely pathogenic gene was found in 6 patients. Pathogenic association was seen in 3 patients, and 2 patients had mutations of uncertain significance. Only 1 patient did not have familial history of congenital aniridia. 2 patients showed mutation in 2 other genes, along with PAX6 gene, FBN1 gene, which is found to have association with Weil-Merchandisani syndrome, and CRY-GC gene associated with multiple types of cataract. This is the pedigree chart of the first family. As you can see, the mother there was no in the first and second generation there was no affection. The mother and her 2 children had aniridia. Case A, which is the mother, she had congenital aniridia with glaucoma, nystagmus, limbal stem cell deficiency, and bilateral corneal opacity. Both we can see that she had only PAX6 gene mutation. Case B, her son, also had only PAX6 gene mutation with aniridia, micronystagmus, flat cornea, and fundus examination showed foveal hyperplasia. Case C, her daughter, found to have partial congenital aniridia, cornea plana, nystagmus, and LSCD. She also had only PAX6C mutation. Second family, wherein 2 sisters were noted to have aniridia along with their father. Case D presented with clinical indications of congenital aniridia with nystagmus, pseudophakia, severe foveal hyperplasia. Her father could not be he could not come to the OP because he was abroad. Her sibling was also similarly affected. PAX6 gene was found to be affected in both. The third family, wherein the father and the son and daughter were affected. The father, case F, was born of non-consanguineous marriage. Clinical indications of nystagmus, cloudy cornea, and glaucoma since 2 years of age. PAX6 gene again. And the son, case G, was found to have CRY-GC, and of course congenital bilateral cataract along with glaucoma and nystagmus and aniridia, along with a history of leukemia. which was subsequently treated. His sister had aniridia, ptosis, nystagmus, and bilateral cataract, but she had only PAX6 gene mutation. The fourth family showed the father and son were both affected. His son, the father had PAX6 gene mutation, and the son had PAX6 with FBN1 gene mutation, but no features of elasticity were noted in this patient. He also had glaucoma, bilateral cataract, and congenital aniridia. The fifth family, we could see that this was a unique case where there was no family history of aniridia. She had nystagmus, foveal hyperplasia, and strabismus, and only PAX6 gene was noted to be affected.
Will you conclude?
Molecular genetic revelations can pave way for better identification, and we observed intrafamilial variability of phenotype, and our study supposes the hypothesis that a mutation in PAX6 gene correlates with the expression of aniridia. It did not reveal any evidence of sporadic inheritance, and no evidence of those who are affected with FBN1 gene and CRY-GC did not show any new associations that could be thought about.
Thank you.
Thank you.
Sorry, can you hear me? Yeah, thank you. So this is interesting. Most of your cases were familial. Okay,
Yes, ma'am. Yes,
so most of them had features of aniridia in the child.
Yes, ma'am.
What was the genetic test? Did you do a whole exome or a chromosomal microarray?
Ma'am, we did a whole exome sequence.
So in that case, when there is a familial aniridia and phenotypically you are seeing aniridia, a chromosomal microarray would be the study of choice in this case, okay? If this is something sporadic, then you have to look for things like Vagor.
Exactly.
You have to do an ultrasound. Then
Yes, ma'am.
maybe you can think of a whole exome. But
Yes,
when
ma'am.
you already have a familial,
Yes,
then
ma'am.
chromosomal microarray should have been the... So you don't get all these 1,000 variants of uncertain significance, and then you don't know what to do with them, and then you can't phenotypically correlate what you're seeing genetically, isn't
Yes,
it?
ma'am. Yes, ma'am. That is, I'll note that next time.
In which city this study was conducted? In which city this?
Kozhikode, so Calicut, in Kerala.
Kerala.
Yes, sir.
And what is there any history of consanguineous marriages on that?
No, none of them, all of them were born of non-consanguineous marriage, sir.
Okay, fine. Did you take in the study?
Yes, sir. Yes, sir.
And what is the main aim? Because you are not.
Basically, sir, we wanted to see if we could.
No, for the society, what in final for what conclusion you give to or advice give to the family? What?
Sir,
something?
basically genetic counseling, which we already know about, but we were wondering if, there are various presentations of aniridia. So we were wondering if we could, through a whole exome sequencing, which was only available at that time.
Okay, so
Microarray was not
contribute
available
for
at
the
that time.
literature.
Yes, sir.
Good.
Dr. Himanshu, next present.
Thank you.
I'll request Dr. Pragya to be ready for the next presentation. Dr. Himanshu.
Good afternoon all. Today I am going to present my report on retinopathy of prematurity in small for gestational age versus appropriate size for gestational age premature infants, which was a prospective study. There were no financial disclosures. So coming to the introduction, as we all know, retinopathy of prematurity is a proliferative fibrovascular disorder affecting the peripheral retinal vasculature in premature infants of low birth weight and young gestational age. So with improved survival of sick premature and very low birth weight babies and with good neonatal care, there has been a steady increase in incidence of retinopathy of prematurity. So emergence of ROP depends on interaction of multiple factors which we all know, such as gestational age, low birth weight, hypoxia, duration of oxygen supplementation, and all others. So a small size for gestational age is a very less studied risk factor. So we designed a study to compare size of gestational age with incidence and severity of ROP in premature infants. So this come to our aim to compare the incidence of ROP in small for gestational age with appropriate size for gestational age infants in central India. So, coming to material methods, it is a prospective comparative observational study conducted in GMC Bhopal. So, ethical clearance was taken from Institutional Ethics Board. This study was conducted for 18 months, and all the premature infants with gestational age of less than 37 weeks and weight less than 90th centile were included in this study. Data was collected in preformed proformas and entered into MX Excel sheet and analyzed accordingly. So coming to the result, as we can see, we have seen 16% of the appropriate size for gestational age infants having ROP compared to SGA, which was 18.4%. So as we can see here, so the p-value is only significant in 29 to 31st week of infants in SGA and AGA. In other gestational age, above 32 weeks, it is non-significant, and below 29 weeks, it was also non-significant. So as we can see, distribution of severity of ROP, it was also non-significant in AGA and SGA infants. Severity, it was also came non-significant in AGA and SGA infants. So coming to the discussion, so in our study we have total 603 neonates which met inclusion criteria, and these were included in our study. So in our study 353 infants were AGA and 250 were small for gestational age. So this study shows SGA infants with gestational age of 29 to 31 weeks were more prone to develop ROP than their AGA peers. We are not able to find any significant difference below 29 weeks of gestation, supposedly because there were no low numbers of the patient below 29 weeks. So there were similar studies such as C.A. Dhaliwal et al. In 2008. He also found that SGA infants born at gestational age of less than 32 weeks are more likely to develop ROP, but they also haven't got any severity more in SGA infants than AGA infants. So Lundgren et al. In 2014, in their study concluded that SGA infants for gestational age between 26 to 32 weeks are at higher risk of developing ROP. Similar study was Thokre et al. In their study, they found that ROP incidence was higher in SGA infants compared to AGA infants. They haven't mentioned the weeks. So Carrot et al. Have also observed SGA as a significant risk factor for development of ROP. So a systemic review, there was a systemic review which concluded that the SGA is an important risk factor for development of ROP at any age of ROP as well as ROP needing treatment. So to conclude, small for gestational age premature infants at gestational age 29 to 31 weeks are more likely to develop ROP than their corresponding AGA peers. And SGA infants of birth weight less than 1000 grams were at higher risk of developing ROP than AGA infants. No significant difference was found in any other weight groups. No significant difference for severity of ROP was also noted. These are my references. Thank you.
AGA, you have written.
Ma'am, small size for gestational age and appropriate size for gestational age. This was based upon the growth charts which are mentioned in Apgar score also. So from
they have that scoring system for that. How do they classify it as this?
Yes, ma'am.
So who had helped you, the neonatologist, to classify this?
There are charts. There are charts available. So we can divide based upon the charts, which was HGA, SGA. These were percentile charts. So 10th, less than 10th percentile infants are small for gestational age. 10th to 90th percentile infants are appropriate size for gestational age, and more than 90th percentile are known as larger size for gestational age.
Okay, so if there are twins who are of the same gestational age with different birth weights, so it could be small or whatever. So are you trying to say that the incidence or the risk of development of ROP will be smaller in the smaller size twin, and in that way do you counsel your families that way, and have you noticed that? Because when you talk about so in this case what the gestational age is the same, the main criteria that you're using is the birth weight. Okay, both these as per RBSK guidelines are important for development of ROP, but it's not that the birth weight is more important than gestational age or vice versa. So in case of twin pregnancies where the gestational age is the same, can you say or have any of the twin pregnancies concluded that the smaller gestational age infant developed treatable ROP? So that is something you need to look at when you...
Ma'am, we have looked into that also. We have seen twins in these studies. And in most of the twins, they were comparable size and both were small for gestational age. And
True, they will be small for gestational age. But when you are looking at the comparison, so you mean to say that both twins were a similar birth weight?
Both were small, matlab less than 10th centile.
Agreed. But there will be one larger twin baby as compared to one smaller baby.
Yes.
So have you looked at the smaller birth weight baby developing more incidence of ROP, which is leading up to treatment? That is what is going to, what you're going to extrapolate from your study, isn't it?
We have seen those in most of the twins pregnancy, both of the infants were equally affected. Yes.
Okay, thank you.
Dr. Pragya.
thesis होगा
Thesis, okay, good.
thesis होगा और क्या
And your tabulation is just your quotient, just your data should be like very AIOC में दिखता है ना फोटो सबका कौन सा कैरेक्टर है, your data should be like that. दिखना चाहिए, पढ़ने का टाइम नहीं होता, ठीक है? जो दिखता है वही दिखता है.
Good afternoon. I'll be talking on agreement of intraocular pressure measurement using rebound tonometer IK or IC200 and applanation tonometer in children with pseudophakia and aphakia. Glaucoma associated with aphakia and pseudophakia is as high as 41% depending on the length of follow-up. Signs of glaucoma are elevated IOP, optic nerve head cupping, myopic shift in refraction. Among various IOP methods of measurement, Goldman is the gold standard, while eye care RT is an anesthesia-free handheld device which works on solenoid mechanisms. Intraocular pressure readings are affected by CCT in applanation and rebound tonometers both. Our aim was to compare the IOP measured by rebound tonometer, eye care IC200 and applanation tonometer either by Goldman or Perkins in children with aphakia and pseudophakia, and to assess the effect of CCT and axial length on IOP measured by two tonometers. A prospective and comparative study for a duration of 5 months, including pseudophakic and aphakic children of 2 to 8 years age group, excluding eyes with corneal scar and irregular Myers, were included in the study. Demographic data and surgical details like age, sex, lens status, any pre-existing glaucoma was noted. Clinical examination included best-corrected visual acuity, spherical equivalent axial length, and central corneal thickness recording. IOP was recorded first by a rebound tonometer, and after a gap of 5 minutes, applanation tonometer either by Goldman or Perkins was recorded by other observer to avoid the massage effect. Successful attempt was when reliable readings were obtained by 2 tonometers, and when above criteria was not followed, the attempt was counted as unsuccessful. Statistical analysis was done with SPSS system, and blunt alignment plot was used for agreement between two methods. These are demographic data of 137 eyes, out of which 86 had a successful outcome, and the mean age of our study was 5.2 plus minus 1.81. Spherical equivalent axial length, CCT and best corrected visual acuity were looked for factors affecting outcome of IOP under generalized estimation equation, but none were found significant. The total mean IOP difference was 3.4 plus minus 3.6, which was statistically significant, and the mean aphakic IOP difference was more as compared to the pseudophakic eyes. An agreement between RT and AT IOP with less than 21 mm edges showed moderate agreement with ICC value of 0.51. However, in more than 21 mm, poor agreement was noted. An agreement between rebound tonometer and application with CCT showed poor agreement in thinner corneas, and moderate agreement was noted in 501 to 600 micron corneas. The moderate agreement was also noted in more than 600 micron CCT corneas, but the standard deviation was quite higher. To the best of our knowledge, there is lacune in literature comparing IOP in pseudophakic and aphakic eyes in Indian pediatric population. So we evaluated the agreement in order to ease the process of monitoring of IOP without compromising the accuracy. The mean difference noted in our study was 3.4 plus minus 3.6, which was comparable with Pushti et al. However, it was higher as compared to the different comparable studies. The mean difference was lesser in less than 21 mm eye group, which was comparable with other studies. The standard deviation are more in baseline higher IOP, which was comparable with other studies. However, it was contrary to Gao et al. Study. We found a weaker correlation with CCT and applanation IOP with RT, and this correlation was more with rebound tonometer, which was comparable with Sujata V et al. And Gao et al. Study. And the mean difference increased with increasing CCT, which was comparable with Sujata V, Devang and Pushti et al. These were limitations of our study. We conclude that in eyes with IOP less than 21 mm Hg and CCT of 501 to 600, the agreement was found to be moderate. So it can be used as an alternative for applanation tonometer. However, in eyes with higher IOP, thicker corneas, and higher eye care IOP is an indicator for EUA and must not be relied upon to make any diagnosis. These are my references. Thank you.
Still gold standard for measurement of for you.
Sir, Goldman applanation tonometer.
So, examination under anesthesia. So we already prefer for the gold medal of Perkins, like
yes, sir.
Applanation tonometer is the gold standard.
Yes, sir.
So what made you think you should do study on these things?
Sir, when many times patient is not cooperative, we have to perform it under.
I'm talking about the examination under anesthesia.
Sir, pardon your question, sir.
Examination under anesthesia. So I'm asking you, what made you think to do these if we have good gold standard
yes,
like method or applanation tonometry? So.
Sir, if we get higher IOP with eye care, and then that patient may require EUA to.
That's why I'm saying these are still not reliable. When things are going unpredictable, we don't know.
Sir, yes, sir. But that only we tried to study whether in if baseline IOP is less than 21. And normal ranges of CCT, can we rely on eye care or not? That only we had tried to look
so we
in
never
this
rely
study.
I think.
But child will be moving his eye, na? So child will be moving the eye, so you might not get a central reading with the rebound, you might get a peripheral reading.
Yeah.
In that case, you might get a high reading, and that doesn't mean that you go for an EUA. I mean, that is an erroneous reading what you're getting from your conclusion, what you're saying. That you have higher IOP, you go for EUA. So that is an erroneous reading. It's better would be that obviously you would put this patient as seeing under EUA and do a gold standard,
yes,
rather than having an erroneous reading and then going for EUA.
Yeah.
Yes, sir. We tried to take.
That's why they are never reliable. Maybe false positive or false negative. So these are
yes,
the,
sir.
like rebound
Yes,
basis.
sir. They are not reliable.
So, yeah. So and calibration is not there of instrument.
Yes, sir.
So, but what is it like?
That eye care, it has that position when this eye care IC200 that had that position. The color changes green and red like that. Okay. But centration is still not verified with that, sir.
Okay.
Dr. Kirandeep, next presenter. The next presenter is Dr. Veena after this.
Good afternoon, one and all present here. So I'll be presenting the topic ChatGPT as a virtual educator, evaluating its efficacy in amblyopia patient communication. The authors have no financial disclosures. So we know that artificial intelligence-based chatbots are increasingly being used to obtain information for education, research, and healthcare practice. ChatGPT is one of the latest artificial intelligence-based large language models, which is hyped to create human-like responses. With the extent of its popularity and use among general public, its potential in answering health-related queries is an interesting underexplored aspect. So we know there are few studies that have already looked into the performance of ChatGPT in ophthalmology. The roles have been explored in generating discharge summaries and operative notes as well, and the performance of ChatGPT across various board examinations. So the purpose of our study was to assess responses generated from ChatGPT-4 to a frequent pediatric ophthalmic condition, amblyopia, and to assess its application in medical education. With an eye towards the future, this study aims to contribute to the ongoing consensus on integrating artificial intelligence into medical practice. So this was a cross-sectional study. The sessions were conducted on 30th of September 2023 using an online virtual platform, ChatGPT-4. So a set of 13 common amblyopia-related queries were framed, and answer to each query were generated twice from ChatGPT, and the responses were later on evaluated by 5 ophthalmologists with a minimum of 2 years experience, and these were scored from 1 to 5 based on the assessment from very poor to very good. So the median scores were computed to quantify the evaluated responses. The interrelator reliability was checked using Fleece-Kappa coefficient. Kruskal-Wallis H test was used to detect the significant differences in scoring among evaluators. And violin and box whisker plots were employed to visually represent the score distribution. This methodology aimed to provide a robust evaluation of ChatGPT's utility in addressing queries related to amblyopia. So this is the summary of evaluation scores for amblyopia-related queries. We noted that for majority of the queries, the median score was 4, except for the etiology, which had a median score of 3, and the range was from 3 to 4. And the question that if the patient could go blind if untreated also received a median score of 4. So this is the table showing distribution of different scorings by each evaluator. So majority of the questions, they received a score of 4, that is good responses were received, followed by score 3 that showed acceptable but incomplete answer to the questions, followed by score 5, and one question received a score of 1, that was a very poor response by one evaluator. So this is the table showing comparison of inter-evaluator scores, and the mean percentage of agreement among different evaluators was 74.77%. This is a violin plot of different evaluators which show that there was a general agreement among evaluators, especially around the median score area of 4. And this also indicates that major scores were favoring towards the higher end of the score with fewer scores towards the lower range. This is the individual violin plot of studies scores received from 5 evaluators. And this showed that evaluator 4 had a tendency of giving higher scores on an average, and evaluator 5 was most conservative with scoring, and evaluator 4 had the least variability among the scores given. So this is the box whisker plot of the evaluation results, which was in correlation with the above plots. So we know that in past months there has been a significant interest in examining the utility of large language models in medicine. Sakai et al. In their study found responses from ChatGPT to be 70% accurate, and the highest accuracy was in field of blepharoplasty, orbit and ocular oncology, and it was lowest in pediatric ophthalmology. Nigdal et al. Evaluated ChatGPT responses for amblyopia and myopia and found an accuracy of 81.5% and 87.5% respectively. Our results were almost similar, with showing an acceptable results of 84.6%. The strengths of our study are that we have integrated the AI-powered tools like ChatGPT into medical education. This is the first study which has extensively analyzed the responses on amblyopia, and 5 ophthalmologists were included to eliminate any bias in scoring and evaluation. The limitations include the diversity in evaluator opinions, highlight the complexity and subjective variation in interpretation, and we did not actually give any case-based scenarios, which we feel are more common. There is a more chance that parents might give prompts like case-based scenarios to understand the prognosis and treatment for their child. To conclude, ChatGPT has a potential to serve as a valuable educational and informational tool for pediatric ophthalmology patients and caregivers by demonstrating a relatively good performance. But we also identified areas like etiology and prognosis which need refinement and enhancement to enable accurate knowledge dissemination. Thus, artificial intelligence models must continue to evolve and adapt to bridge the gap between AI-generated responses and healthcare professional expertise. These are my references. Thank you.
You made 2 exceptions. First,
of
No,
doing
but
this.
none you did this. So this is exception. Nobody else has this in the morning. So this is your crime, so we'll cut your number. That's a mazak hai. But GBT is my favorite subject. So what is GBT? GPT-4
So,
plus.
so basically, like ChatGPT, it is coming as an artificial intelligence model.
GPT-4 plus, what is that?
Sir, we have used GPT-4. 3.5 is the free version that is available.
Did you use professional version?
We use the professional 4 version, yes, sir. So 3.5, actually we initially started with 3.5, but we found the responses were really not good. So we took a paid version and did with the ChatGPT 4. We did the study because.
It's not like the GPT is doing all the AI building. We need to again see and look. So they are also doing. And best part is that when they commit the mistake, AI is commit mistakes, they ask you sorry, and he say thank you for correcting me. That is the best part I like till the date. Otherwise,
Yes,
it's still in the progress, and it's good for many things like writing letter and all these things, applications. Make are you married? Just asking or not? Married. So it's good for doctors who have small kids and not getting a chance to doing their kids' homeworks. So that you do your professional work for yourself and your kid work with GPT. So we all must learn GPT for other works. Otherwise, in the medical field, long way to go. Because artificial is artificial and natural is natural. So it's long way. Still, we have 50 years to replace our.
Yes, sir, yes, sir. So there were prompts where we found some like fallacies, like particularly related to prognosis.
Good study. Just on the.
Yeah. Dr. Veena for the next
Study.
presentation.
Just one quick question. You can, when you put up your questionnaire also, no?
Ma'am, in lack of time, like I had, it's in the hidden slides.
Right. That's a new thing you have tried.
It's in the hidden slides actually because of the
That's
time
a good
limit I
thing.
had.
It's new thing you have tried.
The results are questionnaire based, so I said.
Ma'am, I just put the highlights like it was based on the definition cause, that one thing.
Next time आपकी जगह AI present करेगा.
Thank you. Yeah, next presentation.
Good afternoon, everyone. I don't have any financial interest in this presentation.
Closer to the mic.
In the past 2 decades, there is a multifold increase in the survival of children, preterm children, because of the better care. And this results in an enormous increase in children requiring intervention for ROP. As a pediatric ophthalmologist, we are worried about the long-term sequelae, if it goes unnoticed, will end up in preventable blindness. So we wanted to study the prevalence and association of refractive error and strabismus with children in ROP at a much earlier age group at various intervals, and to compare it with the regressed ROP and the children who took treatment. Around 96 children were included in the study. All children at 6 months of age diagnosed with ROP, whose parents were willing to participate, were included in the study. And children with stage 4 and 5 were excluded. Children with other ocular disorders and who had ocular surgery and major systemic illness and children with CP were excluded from the study. They were divided into 4 groups, depends on if they have spontaneous regression or what type of treatment they have taken. Patient-related history was taken from the parents, and information about ROP and the treatment was obtained from the patient record. Each visit, visual acuity, refraction, and cycloplegic refraction were examined using an age-appropriate method. Anterior segment evaluation and orthoptic evaluation was done by the pediatric ophthalmologist, and the retina evaluation was done by the retina surgeon. Coming to the results, children with stage 1 was 34.4%, and children with stage 2 was 33.3%, and children in stage 3 was 27.1%. 2 children had cicatricial ROP, and 3.1% of the children had AP ROP. And most of the children had laser treatment. 34% of children had no treatment, and they regressed spontaneously, and 6.3% of children had only injection. Children who didn't respond to injection or who had recurrence after injection were given additional laser. So it was observed the prevalence of myopia increased over time from 35.6% at 6 months of age to 41.8% at 24 months. Like many other studies, we also saw the incremental increase in the magnitude of myopia. The myopia was more prevalent in zone 1 and zone 2 posterior compared to zone 3. And coming to the stage of ROP, stage 3 ROP and who had plus disease had more of myopia and hypermetropia compared to stage 1, 2 and who didn't have plus disease. Coming to the treatment part, it was so obvious children who had injection and additional laser had the maximum prevalence of myopia and high myopia, and it was least with the children who had only injections. It was in correlation with the BEAT study. Most of the children had with the rule astigmatism. Children with plus disease had maximum of astigmatism, and children with injection and laser group had maximum astigmatism, but it was not statistically significant. Coming to the mean spherical equivalent, you can see there is an obvious significant difference over the visits. 6 children had strabismus, 4 of them had esotropia, and 2 of them had exotropia, but we couldn't find any correlation between zones or stages or treatment. So prevalence of myopia increased over the time. Incidence of developing myopia varied among the treatment groups. There was no association with other factors with squint or anisometropia, and the magnitude of astigmatism remained fairly constant over the period. From the pediatric ophthalmologist's perspective, all of us understand the difficulty in treating the preterm children, making them survive, treating them for retinal problems, and leaving them blind just because we undiagnose or delay the diagnosis of refractive error. So I want to insist the proper protocol which should start as early as 6 months of age and should be followed up periodically, whether they belong to the observation group or if they have taken treatment. That doesn't matter, because 30% children in observation group also have refractive error. So strict protocol should be followed even after their retinal maturity completes. Thank you.
Where this study was conducted, center, secondary or tertiary somewhere, or like
tertiary care center.
Tertiary care, and how many investigators were there? Investigators. Yeah, you have collected hospital data. How did you collect your data?
From our hospital EMRs.
EMR, okay.
EMR.
So this is a retrospective.
Yes, sir.
Okay.
Sir, this was a prospective observational study.
Okay, okay.
Only the retinal treatment part we collected from the EMR, but progressively we followed the patients after 6 months of age.
One thing is like again, Meher is there. After laser group, myopia is going to increase. So something after hitting laser is going in vitreous. What is the reason? That could you try to find it out?
Sir,
like yeah.
It is like many studies quote that because of the anatomical changes and the destructive part of the laser, which causes it, but we didn't really go into the details of how it is causing.
Still, we didn't know that. Okay, good.
Yeah. Next speaker is Dr. Ashok Kumar Singh.
Good afternoon, everyone. Thank you, AIOS, for giving me opportunity to describe our study done on assessing the prognostic significance of CYP1V1 variant in childhood glaucoma and insight from a prospective cohort study. So we all know that childhood glaucoma is unpredictable. The same disease may differ in onset, severity, and symptoms. Even the outcome is variable. With the same surgeon performing the same surgery, the outcomes can be quite different. CYP1V1 has been identified as the leading cause of PCG, and more than 150 mutations of CYP1V1 has been found to be associated with PCG. But these mutations have not been studied in great details, but a few case reports are there in the literature which shows that these mutations can be quite variable with respect to their presentation, prevalence, and outcome. like if we look at the most common variants present in the North India and South India, they are quite different. So why this variability? Are we generalizing the phenotype? Because most of the previous reports describe all the children with ophthalmos, hazy cornea and raised IOP as PCG. And even we are not sure whether the genetic variants actually represent PCG or some other non-ocular acquired anomalies. So in this regard, we did a study in which we recruited the intractable glaucoma patients who required multiple surgeries and had persistent corneal scarring. 12 out of the 13 patients had CEP1V1 mutation, and 9 of these 12 had homozygous variant for arginine 390 histidine. So we label them as neonatal onset CEU. So with this background, we aimed at studying different CEP1V1 genetic variants found in a cohort of children with non-acquired glaucoma and to analyze their correlation with the phenotype and the outcome. So it was a prospective cohort study. All non-acquired glaucoma children who underwent clinical exome sequencing between January 21 and to January 23 well included. Genetic test was done and the pathogenicity of the variant obtained was determined using ACMG guidelines. Children who had 6 months of post-operative follow-up after surgery were finally analyzed. So we had a cohort of 175 children with non-acquired glaucoma who underwent clinical exome sequencing. PCG was the majority of formed the major chunk of this cohort, followed by CEU, congenital ectropia, UVA, ARS, and iridia were the other diagnoses. If we look at the genetic variant-wise distribution, CEP1V1 was the most common genetic variant that we obtained, followed by PAX6, FOXC1, LTBP2, FOXE3, and PTAX2. Now, we had 52 out of these 175 children with CEP1V1 variant. If we look at the genotype-phenotype correlation of these 52 children, we noted something interesting, that all the children who had arginine 390 histidine variant, whether in homozygous form or heterozygous form, were clinically diagnosed as CEU. And those who were diagnosed who had arginine 368 histidine variant, whether in homozygous form, heterozygous form, even in presence of arginine 390 histidine variant, were majorly diagnosed as PCG. We also looked at the outcome related to the genotype, and we defined outcome as good, satisfactory, poor, based on the IOP medication requirement and requirement of surgery. So if we look at this table, we note that about the patients having arginine 390 histidine variant had very poor outcome. It was worse in the cases of homozygous condition, but equally bad in compound heterozygous or heterozygous conditions. But all those children having arginine 368 histidine variant had very good outcome, whether they were homozygous, compound heterozygous, or even in presence of arginine 390 histidine variant. Patient with mixed variant had no specific patterns. So in our cohort, most patients with homozygous CEP1V1 arginine 390 histidine variant were phenotypically neonatal onset CEU. PCG was found to be associated with arginine 368 histidine variant. So we could identify one uniformly poor prognosis variant and one good prognostically significant variant. So the take-home message is that knowing about the gene mutation is not sufficient. Knowledge about the different variants are also very, very important. Thank you for your patient listening.
It's very good study. I think it's very useful.
Before operating, we should all, if PG will, so do this study just beforehand discuss the prognosis with the
Yes,
parents. Because now litigation is there. Court is heavily on pediatric ophthalmologists. Everything is going, we are getting nothing. But if anything went wrong after even 20 years, when you are like with your grandchildren, you are heavily monetary loss or something, you may be jail. So
Yes, sir. Yes, sir. So that's the biggest advantage we had from this study. Like we are now in position to counsel the parents, like how will be the prognosis of the child based on the genetic study. So.
Sure. I just wanted to ask, so
Yes,
other than these two variants, was there any other variant that you picked up in your cohort?
Ma'am, actually we have picked up a lot of genetic variants.
Yes, and are you able to prognosticate? Are you able to prognosticate their phenotypic progress?
Yes, ma'am. Even in other cases like with ARS, with aniria, we got multiple variants, and we are coming with those studies. We are analyzing those data.
And how many did you do a segregation analysis on?
Ma'am, almost we try to do on most of the patients, most of the parents, but
number
around 50-60% we do.
Did a segregation.
Yes, ma'am.
One thing more for all of us, you all these data because conference data doesn't go in publications. So these good studies should be because they are savior for us in the next few years.
So this is an ongoing study.
Yeah,
so
trying to publish
yes, sir.
in good journal. And
So is it associated with the severity of the disease, this mutation?
Yes, sir. One variant was found to be more severe, arginine 390 histidine.
Literature says this variant is severe as compared to the other variants, other mutations.
Sir, literature has does not have proper data about which variant of CYP1B1.
It is not the variant, it is just the CYP, cytochrome mutation. Yeah, so basically literature has shown that so it has shown that this mutation, cytochrome mutation, causes a much severer disease compared to other mutations.
Yes, sir.
Okay, so what will it help you when you try to decode the variant? Because generally it is accepted that it is a severe disease.
But sir, all patients with CYP1B1 variant had quite variable outcome. Like some patients required just one surgery, and some patients required multiple surgeries. Even then, they had quite refractive glaucoma. So we try to decode that which of the variant in the CYP1B1 mutated patients are related to the outcome. Like one variant,
So what
arginine.
percentage out of all these required just one surgery?
Sir, surgery was done for all the patients.
No, just one versus the multiple surgery.
Sir, about 80% of the patients with arginine 368 histidine variant, they had just one surgery, and they are doing well till 6 months of follow-up. And those with 390 histidine.
Follow-up is 6 months.
Yes, sir, 6 months
So will it
follow-up.
help in any prenatal testing? If you have a familial cause, if you have a familial, would the prenatal testing help?
Sudip sir next.
Obviously,
Would
it will.
would it be an indication for abortion?
Sir, that's too much to say. But we are doing parenting counseling with
because
that,
of the-
that if patient is having 360.
I think we will wrap up that session. I think one more paper is to go for the last.
One more was हाजिक मैं सही बोल रहा हूँ हाँ गलती हो जाए तो माफ़ कर देना क्योंकि उर्दू ज़्यादा अच्छी नहीं है नेक्स्ट आपका इधर है
So I thank AIOC for this opportunity. Good afternoon, respected chair and audience. So I'll be presenting this paper on incidence of aggressive ROP and management with biosimilar ranibizumab and laser in a tertiary eye care center in Eastern India. So nil financial interest. So we are all aware of the normal practice of laser in stage 3 zone 2 plus and the conditions of aggressive ROP where we are not having a very developed retina. And how do we manage these patients? Not only laser. So we have a few definitions which have come up. The aggressive ROP is not the typical aggressive posterior ROP which used to tell before. So this is a IC-ROP classification 3 where we have aggressive disease beyond the posterior retina and in larger preterm infants, particularly in developing world with limited resources. Anti-VEGF is being tried in these patients, started with beat ROP with bevacizumab, ranibizumab in rainbow trial, aflibercept is approved by FDA for treating aggressive ROP, and biosimilar molecules because of the cost, the quantity, and it has proven to be effective in multiple indications, got approval, and now has proven to be effective in ROP2. But there is a thing that recurrence of neovascularization needing retreatment or rescue laser approximately 7 weeks after anti-VEGF were reported in studies as well as all meta-analysis. So the aims and objectives was to find out the incidence of aggressive ROP in between April 21 to April 23, efficacy of this intravitreal biosimilar molecule followed by laser to vascular retina after a specified time interval in regression of the disease in a tertiary eye care center and comparing the efficacy of the drug in different zones of aggressive ROP. So it was a retrospective study in the vitreoretinal department in Atralam. The study was approved by a local ethics committee. Informed consent was taken. A minimum follow-up 6 months was done after the primary procedure. So study calculated aggressive ROP among all the screen babies. Aggressive ROP infants received intravitreal biosimilar ranibizumab in both eyes in a single sitting from one single vial. Weekly follow-up of for 1 month and then 2 weekly till significant retinal vascularization was achieved. And laser photocoagulation was done to vascular retina at a stipulated interval after injection biosimilar ranibizumab. So this was a 5% population, 24 babies who had laser and ranibizumab in the aggressive ROP group. Type 1 disease was seen in 50 babies out of 522 who had only laser. So these were the 48 eyes of 24 babies of aggressive ROP which were analyzed. And this was the average gestational age, 29 weeks out of 13 female and 11 male babies. Time of presentation was average 30 days. Birth weight was 1302 gram. Days of in ICU stage was around 30 days. So all aggressive ROP under 4.5% were treated with anti-VEGF and were lasered after a mean interval of 5 to 7 weeks. Type 1 disease was seen in 50 babies, which required only laser photocoagulation. Complete regression of aggressive ROP was seen in 46 eyes at a median of 5 weeks. 4 eyes had focal elevated fibrous ridge at the posterior laser margin at 6 months after laser. And there was no eye with recurrence of neovascularization or tractional detachment in less than 6 months follow-up. And 1 eye needed additional laser and 1 eye did not turn for follow-up after laser. So if we, this was the tabulation of the aggressive ROP zone 1 and zone 2 posterior. There was not, the difference was not significant in gestational age, in birth weight, in ICUST, on the grades of prematurity. And if you see the last two things, the zone 2 anterior vascularization 5 weeks after ranibizumab was significant in both the groups, almost around 76-72%. And few babies, around 4 babies, progressed to zone 3 vascularization 5 weeks after injection ranibizumab, but the difference was not significant. So this was the demographic data of retinopathy prematurity in India. Their incidence of ROP was high, 32%. We had reduced incidence probably because of more inborn babies, but the first year aggressive ROP incidence was more or less compared to the second year, showing an increasing trend. Ranibizumab was this was a rainbow study which showed that there was no adverse effect to ranibizumab because we used a biosimilar ranibizumab, but 38% of eyes in this trial reached full vascularization after 24 weeks post-injection, and 91% eyes had a disease in zone 2A or zone 3 4 weeks after injection, converting aggressive ROP to a type 2 disease. This was a study from Gujarat which showed that there was a recurrence in 35% of babies in after 7 to 8 weeks of injection. So the limitation, it was a retrospective study, lack of wide field imaging and comparison group with innovator ranibizumab. Laser was planned at a fixed interval to avoid disease recurrence, repeat injection and possible general anesthesia. This may have changed the disease recurrence course and effect of injection in few babies, and long-term follow-up and comparison laser group was not possible. So conclude, incidence of aggressive ROP, which is a potentially blinding disorder, is not insignificant in Eastern India. Biosimilar followed by laser photocoagulation at a specified interval appears to be safe, economic and effective in having excellent structural outcome. All the eyes could be managed well with one single anti-VEGF injection with single laser and avoiding long-term follow-up, repeated injection and general anesthesia in bigger babies and increased compliance, and there were no safety concerns with ranibizumab. So this is one of the cases. Thank you so much for your patient hearing.
Next.
Thank you so much. In the interest of time, we are going to call the next speaker. If there are any questions, we'll take it offline.
Sure. Thank you, ma'am.
Yeah. Please, Ken.
I should welcome you because I think I'm coming regularly for last 25 years, and this is first paper from the GNK in my knowledge. So welcome.
Thank you.
And you are double doctor here. Just start.
Good afternoon, everyone. I'm presenting a prospective cohort study on the role of low-dose atropine, 0.01%, in the progression of childhood myopia. The rationale started with believing that excessive accommodative efforts would lead to myopia, and if we inhibit accommodation, that would stop the progression. It was subsequently seen that 0.01% atropine had additional effects. It inhibits the cholinergic receptors in the cornea sclera, including the alpha-adrenergic GABAergic receptors, which would subsequently inhibit the cell growth and proliferation and inhibit the progression of childhood myopia. We had a number of studies that we took inspiration from, starting from the ATOM-1 study, which was conducted in year 2003 for 1% atropine and RCT, but there was a lot of loss to follow up, and subsequent to that, ATOM-2 study in 2015 compared the efficacy of 1, 0.5 and 0.01% atropine. Since then, we have had a number of studies, and it had shown that ultimately the mean myopia progression with 0.01% atropine was approximately minus 1.38 in 5 years, and that in placebo eyes was the same amount in half the time, approximately 2.5 years. So it showed 0.01% reduced myopia progression by approximately 50%. We did a prospective cohort study in which we evaluated 100 patients for a period of 1 year, aged between 6 to 16 years of age, where we compared the efficacy of low-dose atropine with that of placebo. At each follow-up, we evaluated the degree of refractive error, the axial length, and the best corrected visual acuity. We used 0.01% atropine sulfate, 1 drop at bedtime. We divided the 100 eyes of the 100 patients into 50 exposed and 50 non-exposed. And we took a range of myopia from -1.5 to -10 diopters. And we evaluated them 4 monthly for up to 1 year. And we evaluated axial length and refractive error at each follow-up. We excluded degree of astigmatism greater than 2 diopters, any other ocular or systemic abnormalities, and we excluded patients who developed any allergy or hypersensitivity to use of atropine. Our baseline characteristics between the exposed and non-exposed were fairly similar, where we had a mean age of approximately 13 years in both the exposed and non-exposed population. The axial length was comparable in both the eyes, with approximately 24 mm mean axial length in both exposed and non-exposed, and the refractive error was approximately 3 diopters. And at the end of 1 year, we compared the axial length between the exposed and non-exposed, and we found that the mean increase in axial length amongst the non-exposed patients who did not receive atropine was approximately 0.3 mm, and in that of exposed, which received atropine, was approximately 2 mm. So we had a mean difference of 0.11. Millimeters, and the refractive error increased in both the populations, but the degree of increase was much more in the non-exposed of approximately 0.75 diopters, and among us the exposed it was about 0.25, so we had a mean difference of 0.5 diopters in the 1 year follow-up that we did, which was statistically significant, and it accounted for a percentage of about 20% in the population that received atropine. It's a bar graphic representation where we show the increase in the refractive error between the two populations and the percentage change, which was much more in the non-exposed population. We drew a number of conclusions from our study where we found that 0.01% could effectively be used as a supplementary treatment modalities in childhood myopia. We had only 1 patient that had to be discontinued because of intolerable glare and photophobia. Rest, we did not have any significant loss to follow up in our study. And the percentage change in the refractive error was significantly higher in atropine group than the non-exposed by a factor of 20%. And if we extrapolate these values on a longer duration of treatment, it could yield better results. The progression occurred nonetheless, only the rate of progression was affected. This goes on to show that a progressive error is a prerequisite for starting the treatment, and it also consolidates its use in childhood myopia. And the percentage reduction was only significant when the degree of error was less, and it would further invalidate the use in high myopes. Thank you.
Because of the time constraints, we will take up the final. I think one was semi-final. The best paper from the previous free paper 1 session is from Dr. Mihir Kothari, so I'd like Dr. Mihir Kothari to present his work again. Can you upload Dr. Mihir's presentation, please?
You will have to go to the previous session. 434, FP 434 in the previous session.
We have been just told to have a semi-final. That means you have to compare the 1 and 2 of pediatric ophthalmology session. That's what just.
So good afternoon, and I'm sorry that I'm lengthening the session by 5 minutes. But I assure you that the presentation will give you a good addition to your clinical armamentarium. I'm presenting an accommodation scale which can be used as a ruler or a gauge for objective assessment of magnitude of accommodation in your pediatric patients. I have no financial disclosures. Accommodative abnormalities are quite well recognized in adults and so in children. Most severe in Down syndrome, around 80% children suffer from severe accommodation failure, 50% children with cerebral visual impairment, and a frequently seen accommodation abnormalities in foveal hypoplasia, ectopia lentis, unilateral and bilateral amblyopias, children with strabismus, children who complain of asthenopia, as well as children on various concentrations of low dose atropine would also have abnormal accommodation. current clinical methods like dynamic abrometry and open field autorefractometry are less accessible, expensive, and they tend to underestimate the accommodation. Hence, most of us clinical ophthalmologists would like to rely on dynamic retinoscopy. However, in our survey on pediatric eye surgeons group in Mumbai, we found less than 5% members were confident enough to be able to estimate the accommodation in children using dynamic retinoscopy when it was required. When we use a direct ophthalmoscope and ask the child to look at a distance and then look at an object at near, which is approaching the eye, you will find this kind of transilluminating reflexes in the pupil. A superior crescent tends to disappear and an inferior crescent tends to appear and become bigger as the accommodation increases. As demonstrated in this video, child looking at distance would have a superior crescent, and when the child starts looking at near, suddenly the superior crescent disappears and an increasing size of inferior crescent tends to appear. This we coined the terminology as dynamic distance direct ophthalmoscopy. And we validated these techniques in 2012 and 2019 IGO publication, wherein we found it to have near 100% correlation with the gold standard, albeit with a higher sensitivity. When you interject the lenses in front of accommodating eye to neutralize the inferior crescent, you will be able to appreciate the amount or the magnitude of accommodation that the child might be exerting while looking at it. However, even this technique was not adopted by my colleagues in Mumbai, and hence we decided to get rid of the interjecting lenses altogether and came up with the accommodation rule, which can be then compared with the dynamic retinoscopy. As you see over here, when the child is looking at a distance, we introduced 0.5 diopter steps of plus lenses in order to get the inferior crescent, which simulates what the child would get when he is accommodating. This scale is quite similar to the other scales which are available, which have been used in the past in ophthalmology, like pupil scale, the corneal ulcer diameter scale, or the cup disc ratio, AV ratio, etc. When we compare it with the dynamic retinoscopy, for a 90% power of the study and 5% significance level, we had to have 15 eyes in this study. We had a pediatric oriented optometrist who assessed the accommodation using two techniques in children between 5 and 16 years of age who had normal systemic health and who were visiting a pediatric eye clinic for regular refractive checkup. We had 17 patients, 17 eyes, of which 10 males were evaluated for accommodation at 4 distances, 100 centimeter, 50, 33 and 25 centimeter, and we found a very good correlation coefficient between the two techniques using the accommodation scale and dynamic retinoscopy, albeit accommodation scale had less intra-test variability as seen with low standard deviation, and also it was better in the sense there was less amount of accommodation induced or the lead of accommodation using the accommodation scale because of lack of interjection. Finally, we validated the same accommodation rule by showing it to our pediatric ophthalmology colleagues in our group on 10 different patients, and we found it to have an sensitivity of plus minus 0.25 diopter in assessment of accommodation. At end of the evaluation, we found 95% pediatric ophthalmologists in our group were confident enough to use this technique. The limitation of this technique is the scale was derived from lens interjection technique, and using an app in future could take care of that issue. Finally, you could use an accommodation scale as shown over here as an easy and rapid addition to your clinical armamentarium for a quick assessment of accommodation in pediatric patients. Thank you very much.
No questions. Good study. Just, I think, the time factor.
Have you developed app on this?
Not yet, sir.
I was trying to. Okay. Any publication of this data?
Accommodation scale is not yet published, sir. The previous publications are already there.
I think we got late, so we are finishing late, and we'll take 30 seconds more to get some photo, because we did session, otherwise they will say this, yeah.